So as Claire said, my name's Leslie Patterson and I'm the Senior Manager for Team B at the Commission, and in Team B we cover predominantly the east of the country and the services within that. So the Commission published our medical treatment under Part 16 of the Mental Health Act, Good Practice Guidance, in April 2021. It's a 55-page document, so obviously I'm going to condense it somewhat, but just trying to cover the salient points as much as we can within the time frame we've got. So firstly, what is Part 16? So Part 16 of the Mental Health Act sets out the conditions under which treatment may be given to those individuals who are detained, who are either capable or incapable of consenting to treatment, specific treatments under the Act. So there's T2 and T3 certificates, they're statutory forms, and they provide the authority to treat under the Act. The T2 are consent to treatment certificates, and they're used when an individual is capable of giving informed consent and gives that consent in writing. And then you've got your T3 certificates, which they authorise treatment. So they're used when an individual is either incapable of consenting to specific treatments or is capable but is refusing to give written consent. We're sometimes asked, can a person have both a T2 and T3 form if consenting to some treatments, not others? And that's perfectly fine. It can be perfectly appropriate. Providing capacity and consent should be assessed for each treatment offered. Obviously, you can't be given the same treatment via the same route on both a T2 and T3. An individual can only have one T2 and one T3 in place at one time. But as I said, there's no concern with them having one of each if that's the case, because we know sometimes individuals will be happy to take some treatments and feel the need for it, but other ones not so much. So that's when it would be perfectly appropriate. And just to remember that when a new T2 or T3 form's done, this supersedes any pre-existing form of that nature. And when it's rewritten, all the current treatments need to be put in the new forms, which you've got no more than one T2 and one T3 in place at any one time. So moving on to that slide, it was talking about when's a T2 or T3 form due. So a T2 or T3 form needs to be in place before medication for the purpose of reducing sex drive can be given. There's no debate here, no grace period. If you're wanting to give medication for the purpose of reducing sex drive, then you need to have a T2 or T3 form in place before you do so. For other medication for mental disorder, a T2 or T3 form is required to authorise any medication given after 2 months since any such treatment was first administered during a continuous period of treatment under the Act. This includes any urgent treatment given during emergency detention, and we'll talk about urgent treatment a little bit later. If there's any break in compulsory treatment, however short, then any T2 or T3 form that was in place is no longer valid. So therefore, the process must start again from the date of the redetention. So what I'll do, just to try and give a little bit of utility, I'll give a couple of examples from practice and certainly what we come across within the Commission. So the first example is, imagine that an emergency detention certificate is granted on the 3rd of April and the person's admitted to the ward on that day. They receive IM lorazepam as urgent medical treatment under Part 16, which I said I'll cover later, on the 4th of April. The next day they go into a short-term detention certificate and continue to get as required medication. Then a regular antipsychotic and mood stabilisers commenced on the 6th of April. They progressed to an interim CTO on the 4th of May and a full CTO on the 18th of May. The response to this would be that a T2 or T3 form needs to be in place to authorise any medication for mental disorder from the 4th of June, which is 2 months from the date of the first administration of medication in this period of detention. So although you can see, although the patient was detained on the 3rd of April, they didn't receive any treatment till the 4th, hence why the T2 or T3 needs to be in place 2 months from the 4th of April, which is the 4th of June. Another example we've got here is an individual who's living in the community and detained in a community CTO. So they're in receipt of psychotropic medication, which has been authorised by a T3 certificate. The individual's compliant with their treatment, but unfortunately suffers a deterioration in their mental state. They refuse an informal admission to hospital, so they're admitted to hospital under a short-term detention certificate. So what we need to remember is that any T2 or T3 form in place prior to them being detained on this new order is still valid, so therefore the 2-month rule doesn't apply here. And clinical staff need to ensure that any psychotropic medication which is given is authorised by the current T3 certificate in place. Because obviously they've been on their CCTO, they're still in their CCTO, but they've also been put in a short term, so you don't get your 2-month grace period here because the detention's been continuous, there's been no break in detention. The only exception to this, which again I'll cover, is about the urgent treatment under section 243 of the Act. And the last example for now, before we move on to that, is an individual detained in hospital on a short-term detention certificate that might be prescribed oral antipsychotic medication from the 10th, and the RMO changes this to depot on the 20th of May. Quite often we'll come across maybe the RMO feels that because the depot was put in place on the 20th of May, then the T3 is required from the 20th of July. So that's not the case. So again, it's about any psychotropic medication given in this period of detention. So it would track back to when the oral medication was first given on the 10th of April, hence the T2 or T3 would be required to be in place from the 10th of June. Just a few points to remember regarding this. So when we're looking at the certificates, so clozapine must always be individually specified in a T2 or T3 and reference made to the regular blood testing that's required. It doesn't come under just any antipsychotic given. It's got to be it's got to be specified individually because of the extra legislation and rules and whatnot about it, so that needs to be specified individually. We would always expect that the routes of administration should be specified. For example, oral, IM, subcutaneous, etc. It's not okay just to say olanzapine 10 milligrams. It needs to specify what the route of administration is as well. We would always look for regular and as required medication to be written separately, even if it's the same drug, so it's quite clear what's regular medication it's being consented to and what's more at times of stress and distress. A T2 can be completed by the RMO or any other suitably qualified doctor who's been designated the role of RMO by hospital managers. So that would be perhaps our RMOs on annual leave. Then there would be another RMO designated in their place, so they can also complete a T2, as can the DMP, which I'll mention in a wee minute as well. And I know Mary spoke about that briefly as well. And as I said, because the route's got to be specified, so if a doctor wanted to change someone from oral to depot medication, you can't give the latter until a new T2 or T3 is complete, specifically authorising the depot. And again, this applies even if it's the same medication by just another route. The depot's got to be specified on itself and on one of the lines of the certificate as well. Something else to remember, we're asked as well, that the existing T2 or T3 remains valid even if the RMO changes. Ultimately, this is about the treatment that's been authorised for this person or consented to for the individual. So even if the RMO changes, it doesn't matter whose treatment plan it was. If it remains valid, it remains valid. And the new RMO can obviously go through processes to obviously reconsider, but in the short term, it doesn't matter who the RMO is. That's irrelevant. And lastly, I know Mary touched on this already as well, it must be noted that Part 16 of the Act does not authorise giving ECT to a person who's capable of consenting, but who refuses, and this is whether it's deemed urgent or not. If they're capable, you can't give ECT under Part 16 of the Act if they're refusing. Just a one slide, just talking about DMPs, just a little bit about them and what they are. So designated medical practitioners provide independent second opinions about certain medical treatments given under Part 16 of the 2003 Act. Their role primarily includes issuing the T3 certificates that I've been speaking about. Their role doesn't include providing second opinions for anything else, such as diagnosis or any other aspects of care and treatment. So when it's recognised a DMP visit's required, the RMO will submit a DMP request to the Commission, and then we appoint the independent medical practitioner who provide these opinions about the proposed treatment, and then they'll issue the T3 or they'll enter discussions with the doctor or not issue if they feel it's not appropriate, and that's their role. The Commission makes sure that all DMPs are up to date with their clinical practice and that they understand the legislation and their role in it. And lastly, we are not, however, responsible for their independent clinical opinions, and that's all on them. So I've touched on earlier regarding the Part 16, Section 243. So we've given a couple of examples of T2 and T3 as well, but we've spoke about sometimes urgent medical treatment that can come out with that, and that kind of supersedes that. So urgent medical treatment can be given for a mental disorder without these certificates being in place if the situation is deemed to be urgent, on an emergency, and in the individual's best interests. So under Part 16, the medical treatment can be given to someone who's detained in hospital and who doesn't consent or is incapable if the purposes of the treatment are to either save their life or prevent serious deterioration in their condition, or alleviate suffering on their part, or to prevent them from behaving violently or being a danger to themselves or others. So providing one of these four criteria are met, then you can give medication under section 243 of the Act that's not necessarily on a T2 or T3 at that point in time. So what happens after the treatment's given? So the treatment can be given, it should be recorded on what we would call a Form T4, which the RMO should then send to the Commission within 7 days. And a further point to note is that we frequently come across during our visits that the T4 form is a retrospective form, so it's got to be completed retrospectively after the treatment's been given, and it's a retrospective form to notify us that the treatment's been given under section 243. And it is permissible to record more than one treatment on the form, because it could well be it's within 7 days. So if someone's really particularly distressed over a period of 3 or 4 days and various treatments are given, all deemed to meet the criteria, then that's absolutely fine to record all these in one T4 forms. And just again to labour that point that T4s do not authorise future treatments that have been given, they're only the retrospective notification. We've seen in visits quite often, we'll maybe go and it'll say, oh, this has been given under a T4, or there's a T4 in place in case we need to give this. If that's the case, for all these potential scenarios that might crop up, they should be on a T2 or a T3 form. As I say, the T4 is only the notification sent to the Commission after the treatment's been given. As with every aspect of mental health care and treatment, it's important that the principles underpinning the Mental Health Act and other general principles guide practice. So I won't read them all out, obviously, because you can all read, but a couple of points to note is the importance of taking into regard previous and current wishes. This is especially important if someone doesn't have current capacity to express these. If you know a patient really well and you know they're dead against some kind of treatment, they may not have an advanced statement in place, but you know they're really against something, then consideration should be given to that. I appreciate we need to always act in the patient's best interest, and obviously we also need to at times go against what their current thoughts are and what not are their previous thoughts and wishes, but it's just about making sure when we know our patients and we know what they're dead against or not dead against, we really need to give cognizance to that as well. I think it's also really important that clinicians can demonstrate that individuals have been able to give informed consent if a T2 is authorising care and treatment, and this is where psychoeducation comes in. We know that if consent's truly informed, then people need to understand what they're consenting to, and sometimes we go out and meet with people who are perhaps got a T2 in place, and you have a chat with them, and they've signed it, but if they couldn't tell you anything about what they've signed or what not as well, they're just really compliant. So I think again it's about making sure people, if they're consenting to something, we need to be assure ourselves that they're truly informed and what they're signing. As I say, that's where we would always rely on our psychoeducation and talking to people about these kind of things. So just to summarise, there's just some practice considerations again for clinical staff. So I suppose if you're a prescriber, or even if you're not a prescriber, say you're working in a ward or you're in a community mental health team and there's a new medication being prescribed, there needs to be a check in place to ensure it's authorised by any existing T2 or T3 certificate if there's one in place. So quite often we'll hear that, oh, the duty doctor came in and just wrote someone up for something, and there's no thought that who phoned the duty doctor in. So you know the duty doctor's coming in to prescribe something, so there needs to be a bit of thought about, is this authorised? I mean, is it just because it's prescribed, it's obviously not automatically authorised. Also for primarily our nursing staff, if you're dispensing or administering medication, you must be sure that the correct legal authority is in place for you to do so. And we always talk about, being a nurse myself, you always think about that medication and how things can go wrong. So ultimately, just because it's prescribed, again, if you're administering that depot, you're doling out that medication 4 times a day, you need to be sure that you've got the authority to do so, not just because it's prescribed. And lastly, the value of regular audit can't be underestimated to ensure compliance with Part 16. Robust audit procedures should pick up on any errors, highlight any good practice that's happening in an area, flag up any issues where practice has fallen short, and enable services to put measures in place to mitigate against these. And it's amazing the amount of places you go to that don't have audits. And I mean, we go in every time we go on a visit, we are pretty much doing an on-the-spot audit of all your kind of prescribing, and it's amazing. There's sometimes not, and it takes us maybe half an hour, 40 minutes, and it's done. Whereas it's amazing the amount of places that don't have audit in place. But I think that can't be underestimated, just to make sure everything that's been done has been done legally and lawfully. And that's me finished.